Hi everyone, today I'm discussing about the topic tumors of the thyroid gland. First, we know about the thyroid cancer, that is tumors of the thyroid gland. We know about the normal structure of the thyroid gland, what are the functions of the thyroid gland, what are the abnormalities involved with the thyroid gland, what is the size of the thyroid gland also. Okay, let's see. And what is thyroid gland? Which is one of the largest endocrine gland in the body, which is butterfly shaped, okay, which contains two lobes. One is right lobe and left lobe, which is connected by the isthmus. Okay, then coming to the functions. What are the functions of the thyroid gland? Which maintains the metabolism and body temperature and growth and development of the body. And usually the thyroid gland secretes two types of hormones, T3 and T4. How it's secreted? Usually the hypothalamus influences the thyroid thyronin relative factor, which stimulates the anterior pituitary to secrete uh, thyroid stimulating hormone, which influences the thyroid gland to secrete T3 and T4. T3 means triiodothyronin, T4 means thyroxine. These both are derivatives of tyrosine. Okay, then coming to the size of the thyroid gland, the normal weight of the thyroid gland is about 10 to 25 grams in normal adults, which is usually increases with the age and body weight, which decreases with the increasing iodine intake. Okay, then what is the blood supply of the thyroid gland? We all know the arterial blood supply is about right and left superior and inferior thyroid arteries, which are derived from the external carotid arteries. The venous drainage is about superior, middle and inferior thyroid veins that drain into the internal jugular vein. Okay, and then what are the disorders involved in thyroid gland? Usually too much of thyroid hormone results in the condition known as hyperthyroidism, and insufficient hormone production results in hypothyroidism. Sometimes the hyperthyroidism may result in goiter also, that is Graves disease. Okay, we already know about the Graves disease, we already discussed. Okay, and coming to the uh, histology of the thyroid gland, there are two types of cells. They are follicular cells and parafollicular cells. See, these are the follicular cells which are circular in shape. Okay, the cells lining the follicles are known as follicular cells. These are the cells. In between these cells, there are normal cells are present. These are parafollicular cells. Okay, usually the parafollicular cells usually affects the medullary carcinoma, and follicular cells are the derivation of the papillary thyroid carcinoma, follicular carcinoma, and anaplastic carcinoma. And what is the thyroid cancer? That is, what are the tumors? Means there is abnormal proliferation of cells of the thyroid gland. See, from thyroid gland there are two types of cells: follicular cells and parafollicular cells. From follicular cells, usually the papillary thyroid carcinoma, follicular thyroid carcinoma, anaplastic carcinoma is arises, but only medullary carcinoma is arise from the parafollicular cells. And what is the pathophysiology of papillary thyroid carcinoma? Usually, grossly, this is the papillary carcinoma. Okay, this is the normal thyroid gland in which this is a tumor. What is meant by papillary carcinoma? That means finger-like projections. There are a lot of finger-like projections as seen. See, 1, 2, 3, 4. Okay, this is very soft and grayish white in color. Okay, and histopathologically there are a lot of differences we can see. This is finger like projections. The pattern is finger like projections, and the tumor cells are, see, this blue color of tumor cells in which the nucleus is a prominent feature, like there is orphan Annie nuclei. See, orphan Annie, this is a cotton name, orphan Annie. There is no with empty circled eyes. See, the nucleus is very empty. That means very transparent and ground glass appearance and optically clear and orphan Annie type. Okay, these are the characteristic feature. These are the normal tumor cells nucleus feature. The characteristic feature is the samoma bodies. Samoma bodies means there is a small concentric calcium deposits are seen in the, see, this is the samoma bodies. That means concentric rings calcium deposits are seen. This is the characteristic feature of the papillary thyroid carcinoma. In no carcinoma, this calcium deposits are like small concentric rings are not seen. Okay, these are blood vessels. This is the fibrovascular septa. Why it is fibrovascular septa? The remaining pink color fibers are seen. See, these are the strands, fibers. That's why it is called as fibrovascular core. And coming to the another carcinoma, follicular carcinoma. This is the second most common. Okay, which is usually differentiated by the invasion, in which grossly there is no not such important features are there, but in case of histologically they are arranged in follicles like circular in shape. Okay, but the nucleus is hyperchromatic, that means opaque, not transparent. See, very opaque, hyperchromatic nuclei, and the cells are arranged in follicular, and in which the invasion is vascular invasion. See, these tumor cells are invaded into the blood vessels, and capillary invasion also seen. Usually the thyroid gland is present, the tumor invades the capsule and enters into the vascular. In this follicular carcinoma, both vascular invasion and capsular invasion is more than papillary carcinoma. See, I will tell you now. There is a table which shows the differences. There is a frequency, age. See, papillary carcinoma is usually most common type. There is about 75 to 80% people are affected with this. But follicular carcinoma is least common, 10 to 20%. Medullary carcinoma and anaplastic carcinoma is very least. Usually the anaplastic carcinoma is less than 5%. Okay, usually the age, all ages, you can see in children also papillary carcinoma, but in case of follicular and medullary carcinoma, middle age group. But anaplastic carcinoma usually affects the old age group. And female male ratio, this is also we can differentiate. Only the medullary carcinoma equal ratio, both females and males are equally affected, but in case of papillary 3:1, follicular 2.5:1, but in case of anaplastic 1.5:1. Okay, the genetic alteration also, in case of medullary carcinoma, RET point mutation on chromosome 10, but all these also RET gene, but different ones. And cell of origin we can all know follicular, but this one only parafollicular. Okay, then coming to the anaplastic carcinoma, which is very rapidly aggressive one, very least commonly seen in people. There is about less than 5%, and usually the ratio is about 1.5:1, and old age group are mostly affected. And usually in case of anaplastic carcinoma, all the parts around the thyroid gland, that means trachea, it involves the capsule and blood vessel and trachea, and all of them are involved. That leads to dysphagia, and okay, which involves lungs, brain. Okay, which causes very aggressive manner of the rapidly aggressive. and in which the microscopically they are arranged in sheets of cells with marked heterogeneity. That means there are three types of cells that you can see. There are small cells, giant cells, and spindle shaped cells. Okay, there are three types of cells that we can see under microscopically, histopathologically. Okay. And coming to the last one, medullary thyroid carcinoma, which is which is also most commonly which is usually affects both male and female are equally affected, and middle age group are affected, and frequency is about 5%, least common. And usually the microscopically we can see the pattern of cells are arranged in like a nest. They are arranged in the form of nest-like cells, and tumor cells are normally uniform in shape, and hyperchromatic nuclei is seen, and main characteristic feature is amyloid. That means pink ones is more in malignants, and this parafollicular cells may causes the calcitonin is increased, so that calcium level is decreased. That leads to hypocalcemia. So in case of medullary thyroid carcinoma patients, hypocalcemia is usually occur. Okay, it is usually involved with the men syndrome. It is usually seen in men 1 and men 2 syndromes, men 2A and men 2B. Okay, and these are the common clinical features of the papillary thyroid carcinoma, which involves discrete neck lymph nodes, and cervical lymph nodes are also invaded by the metastatic cancer. But in case of follicular carcinoma, there is dyspnea, hemoptysis, chest pain, and lung secondaries. In case of anaplastic, we can know hoarseness, vocal cord paralysis, hard mass fixed to the surrounding structures, tracheal obstruction, and long-standing neck mass. In case of medullary thyroid carcinoma, which develops in a superior lateral part of the thyroid lobes and pain, local invasion, which is usually familial in origin. Okay. And according to the cancer type, the survival rate is also papillary thyroid carcinoma is more survival rate, which has a good prognosis. Anaplastic carcinoma is the least prognosis. And usually the investigations which involves we all know FNAC and swab collection, biopsy, MRI, CT scan, and ultrasound, radioactive iodine, and thyroid suppression test. These all investigations involved. In case of FNAC, we put the syringe into the put the syringe from the outside of the neck, and then it's in a to and through motion. It can ruptures the thyroid gland loops, then collect the sample and put it under the microscope, and we can see the differences. But in case of follicular carcinoma, the FNAC is not worked out, because in case of this test, only the biopsy is more prominent for this follicular carcinoma, because the follicles are usually known, but the capsular and vascular invasion is not usually seen under the FNAC. That's why follicular carcinoma is not done with the FNAC. The medical management, we can see in case of papillary carcinoma, we can do total thyroidectomy. In case of follicular carcinoma, also near to total thyroidectomy. But in case of anaplastic carcinoma, we can isthmectomy and external radiotherapy. And in case of medullary carcinoma, also total thyroidectomy takes place. And prognosis is more excellent in papillary carcinoma, good in follicular, and anaplastic carcinoma is worst and bad, very bad in medullary carcinoma. See? And so thank you. We can complete the tumors of the thyroid gland. Next we can discuss about the thyroiditis. Thank you.